Thank you very much. First of all, certainly want to thank the Secretary and Janet Wright and Bob for being with us. They couldn't be here, obviously, in person, but I think their presentations indicate the importance of all the work that you all are doing and how it feeds into the national agenda. So what I want to do fairly quickly is bring you up to date. I think you have hard copy on this. This is one of the things I think Bob or maybe Janet Wright highlighted. The issue is not just over 65 here, but it's the 45 to 64 age group in terms of preventable cerebrovascular deaths. And so some of what we hear about today is what are we doing in this particular age group to target those populations, and in particular, subsegments of the population. I think you saw the differences by African American, Hispanic, and so forth, particularly in this age group fairly early on with the onset of stroke. This is the right care model writ large. 2 words to describe it. Think. Okay, that's not the word. The 2 words are packaged innovations. Packaged innovations. There are no magic bullets here. Okay, you all have tried some of that. So here what you see is a lot of patient activation, proactive outreach coupled with state-of-the-art medications, et cetera, intensive ambulatory care, something that Arnie and his colleagues have pioneered, and then what's in the middle there. So we've got to get away from sort of the academic mentality of how do we tease out X versus Y and have 6 different control arms, and we want to isolate the independent effect of X from the rest. No, that's not the way. We're beginning to understand where these things need to be packaged. A technological innovation or a new drug has to be implemented by teams, for example. And how do you motivate teams, and how do you really create change inside organizations, and how do you motivate patients? What's the role of patient activation and engagement? So these are all important. The Right Care Initiative has sponsored university best practices. That's where a lot of this is occurring. The Leadership Summit here today. We have briefs available. I think they're in your packet. And a white paper that Susan Ivey and Hattie have taken the lead on. All of that's available in the way of background. Here's where we stand today. Okay, we are doing better than the country at large. As you saw some of Janet Wright's slides up there too. We are doing better, but there's a long way still to go. 5% increase or controlling blood pressure in California versus almost no change in the rest of the nation. This is over 2008 to 2012. Lipid control, 4.3%. Lipid control for diabetic care, 5%. Blood sugar, you can see as well. So we're headed in the right direction. We have about 22, maybe 18 to 22, have at least one right care control measure in the 90th percentile nationwide. And percentage-wise, that's pretty darn small, 9–10%. 3 out of 10 California health plans are in that category that report data to NCQA. So what I want to do is go through these results here. I'm not going to go over the beautiful charted graphs here. And by the way, I want to thank our team at Berkeley who did just outstanding work putting all of this together. So Ruby Lynn and Laura Spouts, I know, and also Margie Knox was involved in this, perhaps others overseen by Hattie. So thank you to the 3 or 4 of them. And I hope you get a chance to meet them at the break and in some of the discussion groups. But you can see the data here in terms of the hypertension controlled between 2008 and 2012. We went up from 63 to 68%. For that increase, the average for the nation pretty much stayed the same. If we look at lipids controlled, and you can find yourselves there again on the graph for those of you interested in that, again about a 4.5% increase, and again nationwide it pretty much stayed the same. So we are making progress. Here it is for diabetics, lipid control, 5% gain from 43% up to 53%. But think of those who are untouched by the work we're doing so far. And here it is with the blood sugar levels. The California average 71, we've edged it up to 75% now, which is great. And again, nationwide, not much progress has been made. So let's look a little bit at who are the organizations in the state achieving these metrics and how it compares with the top 10 nationally. And what you're going to see here is a pattern of Kaiser in the more organized medical groups and health delivery systems able to do better. And you see this reflected nationally as well. So one of our challenges is going to be how we can get different practice models, perhaps they're more loosely organized now, the IPs and so forth, to achieve some of the metrics that Kaiser and other like organizations are able to do. Because it's folly to think that everybody's going to reorganize and become like Kaiser. There's a variety of models out there that can accomplish this, and we need to work on how to get that done. If you look at the national top 10 here, as you can see, Gunderson has an organized health plan medical group, Tufts, the same thing, Health Partners in Minnesota, the same kind of thing, etc. Harvard, Pilgrim. If we now look at the LDL for heart patients, again, you see the two Kaisers, and then in the national top 10, you see, again, Health Partners, the Dean Clinic in Madison, Wisconsin, etc., etc. Blood sugar control, similar pattern. Sharp shows up here. They have a largely employed medical group. They also work with their affiliated physicians. Sharp is here, and again, we can learn in our own backyard. And the Chinese Community Health Plan in the city largely is doing some great things, and we can learn from them today as well. And then you see again across the country where people stand. And here's the LDL controlled. Again, it's Kaiser and Sharp. And around the country, you see Health Partners again, Optima, etc., the Dean Clinic, and so forth. And here's the blood pressure controlled. Similar kind of story here at Kaiser again, and nationally, some of these more organized or health plans dealing with pretty much exclusive kinds of networks or health plans largely associated with large organized integrated delivery systems and medical groups. And that's the HbA1c level in control. Less than 9% is the metric here. Low number is better here. And you see Chinese and Sharp, actually just Chinese here. And then you see again those figures nationally. Coventry in Illinois, 11% there. So, 2 or 3 observations. One is the top performing health plans have more exclusive contractual relationships with their primary care physicians. And perhaps that enables them to galvanize more of this improvement for patients. And then if you notice among the physician organizations, they are perhaps largely dealing with somewhat more affluent patient populations, which makes it somewhat easier to get the patient activation and engagement, to get some of these metrics under control, or they are these integrated medical groups. And again, as I signaled earlier, the data indicate that the Delegated Independent Practice Association model and similar models don't tend to score as well. It doesn't mean that they can't, but we've got to figure out ways that that might occur. And in my own view, as we have some national data on accountable care organizations that are trying to engage more in this work, particularly around patient activation and engagement. So much of the data you see here depends not only on the medications and the wonderful things you all do as providers and the incentives for health plans. It's got to get to the patient. It's got to get to the patient and their family. They're the ones that have to take the medication and figure out why it is they might want to engage in exercise or change their diet. Not because it's good for them and you tell them to, but because they want to play with their grandson. They want to see their granddaughter graduate. It's the motivational interviewing, element of this. So it's really this package of things that we need to learn more about.